Good morning, ladies and gentlemen. Today, I am going to deliver my talk on the topic disorders affecting cutaneous vasculature. Introduction. The localized structural abnormalities that develop during the vasculogenesis, angiogenesis, or lymphangiogenesis leads to the vascular anomalies. On the basis of clinical and biological criteria, they are divided into the vascular tumors and vascular malformations. This classification has been adopted by the International Society for Study of Vascular Anomalies and is detailed enough to cover all reported entities. For several of the familial forms, a para-dominant inheritance has been established with a combination of germline mutation and a local somatic second hit. That is both the mutation and the somatic changes, where the somatic and mosaic genetic defects cause the more common sporadic vascular malformations. So all the sporadic vascular malformations have a somatic as well as a genetic component. We start with individual disorders of vascular malformation, and the first will be the capillary disorders. The most common capillary malformation which we encounter is a port wine stain. It's a capillary malformation, sporadic, homogeneous, pink, red, or purple macules which are present at birth. And it is usually located on the skin, sometimes on the mucosa as well. As far as the epidemiology is concerned, it is the most common vascular malformation, and it is present at birth in approximately 3 in 1,000 newborns with equal sex distribution. Pathophysiology. This capillary malformation is characterized by dilatation and increased number of capillaries in papillary and upper reticular dermis. The endothelial cells are flat. Immunohistochemistry show normal factor 7, fibronectin, and basement membrane proteins. So it is just an abnormality or malformation. Clinical features. The capillary malformations are pink, red, or purple flat lesions, which are variably sized with a geographic border. You can see this geographic border. Usually located on head and neck region, but can be seen on trunk and limbs. This capillary malformation grows proportionately with the child and persists throughout the life. So there is no self-resolution. The lesions darkens and thickens with age, and the underlying tissue like skin, fat, muscle, and bone can become hypertrophic. It is generally an isolated, sporadic, and solitary malformation. Multiple lesions can be observed in more complex disorders, but generally it is a solitary lesion. Investigations. Most capillary malformations do not require any investigation. However, associated signs and symptoms, large size, multifocality evoke a possible syndromic form which needs to be investigated. For example, on upper face, larger lesions has a high risk of Sturge-Weber syndrome. So we need to have a CNS investigations done. Then segmental lower extremity capillary malformations need scanometry at around 8 years of age to evaluate about the growth discrepancy, which might occur in such cases. Management. The capillary malformations are asymptomatic but can generate important psychosocial distress. Pulse dye laser is now the first-line treatment of these conditions. It reduces the coloration in 75% of patients without modifying the skin texture. The laser treatment consists of several consecutive sessions. Due to pain, the general anesthesia is often used for children. PDL have been shown to be both safe and effective in treatment of port wine stain in infants as early as 6 weeks of age. The earlier the better, because the effect of treatment gradually weans off as the patient gets older. The pulse duration of 1 to 10 milliseconds is beneficial, and energy must be sufficient to coagulate the port wine stain's blood vessels. And generally speaking, the fluence is kept at 6 to 9 joules per centimeter square. If PDL is not available, IPL can be used in a vascular mode by using filters on the range of 510 to 540 with a moderate success. Surgery is done to correct the tissue hyperplasia, which is associated with these capillary malformations and commonly seen on the lip. Sturge-Weber syndrome. The Sturge-Weber syndrome is a severe neurocutaneous sporadic disorder that is characterized by a capillary malformation located on the territory of first branch of trigeminal nerve. So this is important because the chances of getting Sturge-Weber increases when this capillary malformation involves the ophthalmic branch of trigeminal nerve. It is associated with leptomeningeal and or retinal capillary venous malformations on the same site. Estimated incidence is 1 in 50,000. Male-female have equal ratio. As for the common capillary malformation, a somatic activating change has been identified in GNAQ gene. Clinical features. Sturge-Weber syndrome is a capillary malformation located on the forehead and upper eyelid distribution of V1 associated with ipsilateral leptomeningeal capillary venous anomaly and ocular involvement. So the brain abnormalities and eye abnormalities are seen on the same side as that of the capillary malformation. This capillary malformation can even be bilateral or more extensive, even covering the territories of maxillary and mandibular branches of trigeminal nerve and sometimes extending to trunk and limbs. About 75% of children with intracranial vascular anomaly develop seizures, most often before the age of 2 years, with a risk of contralateral neurological deficit and learning difficulties. Usually, the focal seizures are on the contralateral side and the other neurological deficits are also on the other side. Gyral calcification can be observed. Glaucoma occur on the ipsilateral side, that is side of the capillary malformation in 50% of the patients. Investigation. Frontoparietal capillary malformation necessitates a brain MRI, an ophthalmological evaluation of the fundus, as well as the regular assessment of intraocular pressure. Abnormal MRI warrants further neurological evaluation. Management. PDL is used to treat the capillary malformation on the skin. Management of epilepsy and glaucoma is an emergency. It is still questioned if prophylactic anticonvulsant treatment is recommended or not in those patients who still has not developed the seizures. In patients with intractable seizures, surgery or lobectomy may be required. Then regular ophthalmological follow-up is needed throughout life with reduced intervals during infancy. The capillary malformation with arteriovenous malformations. This is called as the capillary malformation arteriovenous malformation or CM-AVM. It's an autosomal dominant disorder which is characterized by multifocal capillary malformations and increasing risk of fast flow vascular malformation. The disorder is reported in over 100 families. Incidence is 1 in 50,000. No sex difference, penetrance is high, and there is important intrafamilial clinical variability. It is caused by heterozygous loss of function mutation in RASA1 gene. Clinical features. All affected individuals have cutaneous capillary malformations. Typically, they are multifocal, but few patients have single lesions. They are of variable size with haphazard distribution. So in this syndrome, it is important that rather than having a single lesion, they are multifocal lesions which are haphazardly distributed. In contrast to common capillary malformation, additional lesions can appear with time until adulthood. This does not occur in the usual capillary malformations. Then the capillary malformations are pink, red, or brown, homogeneous or telangiectatic, and half of them have characteristic white halo around the lesions. So you can see this characteristic white halo here as well as here. In 1/3 of patients with CM-AVM, fast flow vascular malformations are observed. These arteriovenous, you can see these vascular malformations here, and this is the angiography. And these arteriovenous fistula or Parkes Weber syndrome, which is the capillary blush on the upper and lower extremity, bone and soft tissue hypertrophy, and multiple arteriovenular microfistulae. So the Parkes Weber syndrome comes in this category, which is characterized by a capillary blush due to congenital capillary malformation, mainly on the upper or lower extremity, soft tissue hypertrophy, that is both the skin and muscular hypertrophy, and multiple AV microfistulae. The clinical features. AVM, the arteriovenous malformations and fistula located on the face, neck, and extremities tend to worsen with time, causing pain, destruction, localized, and bleeding. The associated symptoms are cardiac failure, hydrocephaly, epilepsy, developmental delay, para and tetraplegia, and neurogenic bladder. Major problem associated with Parkes Weber syndrome is leg length discrepancy causing scoliosis, cardiac overload, or cardiac failure. So both the bone and cardiac abnormalities. Investigations. Once the clinical diagnosis is established, the order for Doppler ultrasound or MRI and arteriography. The leg length discrepancy in patient with Parkes Weber syndrome is followed radiographically. Genetic consultation is necessary to assess family history, and genetic testing can confirm the clinical diagnosis. Management. The capillary malformation or capillary malformation, arteriovenous malformation respond only partially and not all to PDL. So like the normal capillary malformation, this kind of syndrome does not respond well to PDL. And such patients should be followed by a multidisciplinary team specialized in vascular anomalies. The risk and benefit to treat or not are based on symptoms, patient's age, lesion size, location, angio-architectural, and expected evolution. The treatment of patients with Parkes Weber syndrome is as conservative as possible by elastic stockings, and leg length discrepancy is monitored until the end of puberty. Then after that, epiphysiodesis may be necessary. However, this procedure should be avoided whenever possible as it may aggravate the fast flow lesion, and genetic counseling is needed. Angioma serpiginosum. Angioma serpiginosum or progressive, patchy, capillary malformation is a rare congenital skin disorder characterized by non-purpuric, red punctate lesions on an erythematous background. The lesions follow Blaschko lines. Female are more often affected than male with a sex ratio of 9:1 and has a prevalence of 1 in 1 million. Histologically, angioma serpiginosum appear as capillary ectasis in superficial papillary dermis. The disorder seems to be genetically heterogeneous with X-linked dominant and autosomal dominant inheritance. X-linked dominant inheritance is prominent, that is why the frequency is more in female. Then we are discussing the capillary malformations which are associated with localized overgrowth syndromes. Capillary malformations and overgrowth is seen in several disorders, which include the Parkes Weber syndrome, which we have discussed before, the Klippel-Trenaunay Weber syndrome, or abbreviated as Cutaneous, CLOVES syndrome, Proteus syndrome, and MCAP syndrome, or megaloencephalopathy, capillary malformation, and polymicrogyria syndrome. Epidemiology. All these syndromes are rare disorders with prevalence below 1 in 1 million. These 4 syndromes are sporadic. Cutaneous and Proteus syndrome are caused by post-zygotic mutation that is lethal in non-mosaic states. Somatic activating mutations are found in PIK3CA in patients with Parker-Weber's CLOVES and MCAP syndrome, and AKT1 in Proteus syndrome. The clinical features of Klippel-Trenaunay syndrome. The Klippel-Trenaunay syndrome is sporadic and congenital, characterized by asymmetrical overgrowth in girth and length of extremity with a vascular lesion that consisting of combined capillary, lymphatic, and venous malformation. There is often persistence of some embryonic vein on the lateral thigh, which is called as the vein of Servalli, and anomalies of deep venous system, which include stenosis, hypoplasia, and aplasia. The Klippel-Trenaunay syndrome is often associated with localized intravascular coagulation, called as LIC. Rather than DIC, it is a localized intravascular coagulopathy. There is a high risk of thromboembolism and subsequent pulmonary arterial hypertension. This is a case of Klippel-Trenaunay syndrome. You can see a large vascular malformation on one side of the thigh, and there is gradually increase in girth and size of this limb, which is carrying this vascular malformation. Clinical features of CLOVES syndrome. The CLOVES stand for C for congenital lipomatous overgrowth, and then V for vascular malformation, E for epidermal nevi, and S for skeletal or spinal abnormalities. So CLO, congenital lipomatous overgrowth, V vascular malformation, E epidermal nevi, and S skeletal or spinal anomalies. It is characterized by asymmetrical overgrown feet and extensive, usually truncal, arteriovenous, venous, capillary, lymphatic, or combined vascular malformation. It is described in patients which are earlier diagnosed with Proteus syndrome, although several specific criteria of the Proteus syndrome are lacking, and natural history is different. Many patients with CLOVES syndrome have enlarged but not distorted bony structures, and there is no cerebriform connective tissue thickening, which we see in Proteus syndrome. So this is the CLOVES syndrome. You can see the vascular abnormality and apparent on the hand, as well as the bony lesions. Then Proteus syndrome. The Proteus syndrome is characterized by asymmetrical, progressive, disproportionate, severely deforming overgrowth of body parts, dysregulated adipose tissue, epidermal nevi, vascular malformations, and increase in tumor risk. So in this syndrome, there are few typical things. That is a dysregulated adipose tissue, and increase in tumor risk. Typically, this overgrowth is accelerated postnatally. A distinctive feature and clue for the diagnosis is the cerebriform connective tissue thickening, mainly located on palms and soles. Then capillary, venous, or lymphatic malformations are seen. Other anomalies include intellectual disability, cerebral malformations, ocular and renal anomalies. This is my personal case and has been sent as a case report and published about a few years back. You can see this asymmetrical growth of one side of the face, hands as well as leg, with vascular anomaly, with this mixed vascular abnormalities. And here the lipomatous overgrowths are also visible. Then clinical features of MCAP syndrome. MCAP syndrome stands for megalocephaly, capillary malformation, and polymicrogyria. This polymicrogyria is an abnormality which is seen in the syndrome, which is characterized by less deep gyri and having many neurological deficits. There is an overgrowth, brain and body asymmetry, syndactyly, polydactyly, developmental delay, and joint hyperlaxity. The capillary malformations seen in those patients have a patchy reticular pattern with no cutaneous atrophy. The macrocephaly is secondary to large brain and perisylvian polymicrogyria. Investigations. The vascular malformations are investigated as their sporadic, isolated counterparts. A skeletal survey, especially for scoliosis, is indicated. Patients with KTS need extensive analysis of their deep and superficial venous systems, of the affected extremity and the trunk. The D-dimers and fibrinogen measurements assess the severity of localized intravascular coagulopathy. The Doppler ultrasound is indicated to diagnose the soft tissue masses in CLOVES and Proteus syndrome, and MRI is useful before we do surgery. The neuroimaging is must in cases of MCAP syndrome. Management of patients with Klippel-Trenaunay and CLOVES and Proteus syndrome is a multidisciplinary effort, and including the management of overgrowth by debulking and epiphysiodesis with or without amputation. Then treatment of scoliosis and treatment of vascular malformation by sclerotherapy, embolization, and surgery. In Klippel-Trenaunay syndrome, low molecular weight heparin is indicated before any intervention to prevent pulmonary embolism. Management of patients with MCAP syndrome is symptomatic and mainly include follow-up of neurological and cognitive development and management of growth asymmetry. Then genetic counseling is necessary. Now we have come to the 8 arteriovenous disorders. Arteriovenous malformations are congenital, destructive, fast flow, vascular malformation that tend to worsen with time and can occur at any body part. Male and females are equally affected, and the incidence is not known. The AVM can be isolated or part of a disorder such as the capillary malformation AVM, hereditary hemorrhagic telangiectasias, or PTEN hamartomatous tumor syndromes. The pathophysiology. The arteriovenous malformation consists of distorted arteries, veins with thick muscular wall due to the arteriovenous shunting and fibrosis. So this is the normal shunt between the artery and capillary comprising of artery and veins comprising of capillary, and this is the arteriovenous malformation. The origin of AVM is unknown. It is usually sporadic, but underlying predisposing genetic defect exists when it is part of the capillary malformation AVM, like Parkes Weber syndrome, hereditary hemorrhagic telangiectasias, or PTHS. Clinical features. The arteriovenous malformations are localized, affecting brain, skin, and muscle, bone, and viscera. The Parkes Weber syndrome consists of multiple microfistulae. We have discussed this syndrome before. AVM expands slowly, but can worsen rapidly at puberty, during pregnancy, after trauma, and particularly after incomplete treatment. At birth, an AVM involving the skin can appear as a capillary blush, which is misdiagnosed as a capillary malformation. Later on, the presence of increased warmth, thrill, or bruit suggests a fast-flowing component. Evolution of this condition is variable and unpredictable, but many worsen with time and can become life-threatening. The clinical manifestations depends upon the size, its etiology or rheology, and localization of the lesion and age of the patient. This is a particular arteriovenous malformation. If you palpate the lesion, it will be warmer, and if you auscultate, there will be a bruit. The symptoms in childhood and adulthood. The intracranial lesions will manifest as hydrocephaly, headache, epilepsy, hemorrhage, and focal neurological deficits. The pulmonary lesions, pulmonary arteriovenous lesions develop, then there will be cyanosis, clubbing, polycythemia, right to left shunt with cerebral abscess and embolic strokes. Then if there are hepatic lesions, then it may lead to cardiac failure, portal hypertension, and a biliary disease. If the lesions are located only to cutaneous, subcutaneous, or muscle, there is heaviness, pain, pulsatile mass, thrill, trophic changes, which are the deformation, ulceration, and destruction, and bleeding. Investigations. 3 main investigations: Doppler ultrasound, MRI, and arteriography. Doppler ultrasound show high velocity, arterial and pulsatile venous flow with low resistance. It differentiates AVM from vascular tumors, hemangiomas, and other vascular malformations. The T2 weighted MRI show dilated vein and arteries within normal or hypertrophied tissue. It defines the extent of AVM and intracranial lesions and differentiate it from other vascular malformations. Arteriography is done pre-treatment to identify the feeding arteries and localize the nidus where the intervention is to be done. Management. The therapeutic attitude depends on the lesion type, location, and the symptoms. Evaluation should be made by a multidisciplinary team that include a dermatologist, an internist, a pediatrician, surgeon, and interventional radiologist. This may varies from conservative follow-up to aggressive treatment, consisting of conservative treatment like antihypertensives, painkillers, elastic stockings, and wound management. Anti-angiogenic molecules are being tested. Effects of invasive treatments such as embolization and or surgical resections can be devastating, especially if not performed properly, and thus should be performed only in reference centers by trained physicians. Hereditary hemorrhagic telangiectasias, also known as the Rendu-Osler-Weber syndrome. HHT is an autosomal dominant disorder characterized by mucocutaneous and gastrointestinal telangiectasias, which are associated with arteriovenous malformations in lungs, liver, or brain. The incidence is 1 in 5,000 to 8,000. Male females are equally affected. Pathophysiology. The diagnosis of HHT is based on the Kurakio criteria, which includes 4 things. The first is epistaxis. Number 2 is telangiectasias on lips and oral and tongue and other oral areas. Then visceral fast-flowing lesions and family history. The diagnosis is considered definitive if 3 or more criteria are present, possible when 2 criteria are present, and unlikely when 1 criteria is present. Patients with ACVRL1 mutation have a later onset, lower penetrance, with more frequent liver involvement and risk of developing pulmonary arterial hypertension. Patients with mutation in SMAD4 have this HHT combined with juvenile polyposis. You can see the multiple telangiectatic lesions on the tongue and the lips, and there will be epistaxis and similar lesions on the trunk. Contrast echocardiography is indicated. Cerebral MRI, thoracic CT scan, hepatic Doppler ultrasound should all be performed. For asymptomatic AVM in children and young adults, genetic counseling is needed to assess the family history and perform the genetic testing. Blood hemoglobin and hematocrit should be measured annually. The management. Treatment is symptomatic and multidisciplinary. Regular follow-up of oximetry and blood count for anemia and polycythemia. Then iron supplements and transfusion for anemia. Nasal humidification, lubricants for nasal bleeding. Laser can be used for cutaneous, nasal, and GI telangiectasias. Treatment for fast-flowing visceral lesions is similar to that described above. Anti-angiogenic molecules such as thalidomide or bevacizumab, which is the anti-vascular endothelial growth factor A or anti-VEGF-A, are currently under investigation for all such indications. Genetic counseling is also required. Then PTEN, hamartomatous tumor syndrome. This PTEN, hamartomatous tumor syndrome, an autosomal dominant disorder that regroup patients with Ruvalcaba syndrome, or BRRS, and Cowden syndrome. So there are 2 syndromes which are grouped together in PTEN hamartomatous tumor syndrome. One is the Ruvalcaba syndrome and other is Cowden syndrome. These patients have macrocephaly, facial trichotillomanias, papillomatous papules, acral keratosis, benign thyroid disease, lipomatous masses, and increasing risk of developing cancer and vascular anomalies. Signs have sex-specific difference in prevalence, which is estimated as 1 in 200,000. Heterogeneous PTEN mutation is identified in 60% of patients with BRRS syndrome and 81% of patients with Cowden syndrome. So the clinical features. The most vascular anomalies, 86%, are fast-flowing. The extracranial ones are intramuscular or subcutaneous, associated with disrupted architecture, severe and progressive enlargement of the affected muscles. The BRRS is characterized by macrocephaly, developmental delay, hamartomatous intestinal polyposis, lipomas, and pigmented macules of the glans penis. Then the Cowden syndrome is characterized by macrocephaly, the mucocutaneous lesions, which are trichotillomanias and acral keratosis, cobblestone mucosa, an increased risk of benign and malignant tumors, especially involving thyroid, breast, and endometrium. So the Bunion-Ruvalcaba syndrome, it is mainly characterized by macrocephaly. Then there are hamartomatous intestinal polyposis, lipomas, and pigmented macules on the penis. This is trichotillomania, which is characterized by, this is Cowden syndrome characterized by multiple trichilimomas and acral keratosis and cobblestone mucosa. Investigation. Measurement of head circumference can help diagnose a patient with atypical vascular lesion. The penile freckles are frequent in male patients, often a family history of disease, which necessitating genetic consultation and testing. Thyroid and breast ultrasound examination should be done in order to rule out cancer. This should be repeated yearly. Moreover, women older than 30 years of age should have breast mammography yearly. Colorectal cancer surveillance by colonoscopy should be started at the age of 35. The radiological investigations of PHTS, vascular lesions, including the Doppler ultrasound, T2 weighted MRI, and magnetic resonance imaging should all be done. Management. The papillomatous papules are treated with topical agents, curettage, cryosurgery, laser or surgery. Rapamycin seems effective in clinical trials for treatment of PHTS fast-flowing lesions, and genetic counseling is needed. Then we have reached to the venous disorders characterized by venous malformations. The venous malformations are congenital, sporadic, vascular lesions that are characterized by localized light to dark blue lumps consisting of malformed veins. They can affect any tissue or organ. They can be emptied by compression or in the upright position. The venous malformations have an incidence estimated at around 1 in 10,000. Male and females are equally affected. They are sporadic and most are unifocal. Associated diseases. These vascular malformations have D-dimer level elevated in 42% of patients, reflecting increase in fibrinolysis. This localized intravenous coagulopathy is associated with size, deepness, and presence of palpable phleboliths. There is an increased risk of DIC as well, with severe bleeding during interventional or surgical procedures. Pathology. The vascular malformations are characterized by enlarged convoluted venous channels, which are lined by a single layer of flattened endothelial cells surrounded by irregularly distributed smooth muscle cells. Clinical features. The venous malformations are mainly solitary. Less than 1% are multifocal. They form small blebs to large bluish lesions. Palpation is not painful unless thrombosis occur, and there is no thrill or bruit and not warm than the non-lesional area. The vascular malformations can affect skin. It can affect mucosa, muscle, joint, nerve, bone, and internal organs such as brain, GIT, and urinary tract. Depending on the size and location, the vascular malformation can be painful, cause bleeding and functional impairment, and even be life-threatening. The intrabuccal venous malformations are associated with sleep apnea. Migraine is common if venous malformation is located in the temporalis muscle, and on extremities, these venous malformation can cause muscle weakness. This is a venous malformation which is characterized by irregular masses of bluish violaceous color. This is a mucosal lesion of venous malformation, also known as venous lake. The differential diagnoses include inherited mucocutaneous venous malformation, blue rubber bleb nevus, glomo venous malformation, hyperkeratotic cutaneous capillovenous malformation, lymphatic malformation with intracystic bleeding, subcutaneous hemangioma, iatrogenic venous stenosis, and blue nevus. Complications and prognosis. Pulmonary thromboembolism with or without pulmonary arterial hypertension has been reported with localized intravascular coagulopathy. Then venous malformation grow proportionately with the individual and they never regress spontaneously. Aesthetic and functional impairment worsen with time because of its expansion and bleeding, and also depends on the location, and it can even be life-threatening. Investigation. Doppler ultrasound is the best examination to confirm the vascular nature of the lesion, slow flow compared to fast flow in arteriovenous fistulas, and identify the anatomy of the draining vessels. MRI with the spine echo T1 and T2 weight depicts the anatomical relationship between the vascular lesions and the surrounding architecture, which is very important. Management. The tailored compression garment is used for symptomatic and extensive vascular malformation on extremity to reduce pain and thrombosis. Aspirin may help children with painful VMs and elevated D-dimer levels. Low molecular weight heparin is used to relieve pain associated with elevated D-dimer and prevent bleeding during a surgical procedure. Sclerotherapy followed by surgical resection wherever possible is treatment of choice. Pulse dye or YAG laser can be effective for small superficial lesions. Well-localized vascular malformation can be surgically resected, but extensive vascular malformation should undergo several sessions of sclerotherapy with experienced interventional radiologist, sometime followed by partial surgical resection. The sclerosing agents, including detergents, sodium tetradecyl sulfate, polyodecanol, and sodium moruate, then microfoam, bleomycin, absolute ethanol, and radio-opaque ethyl cellulose or ethanol. Rapamycin is promising in clinical trials. Blue rubber bleb nevus syndrome. It's a rare, sporadic, congenital, slow flow vascular anomaly characterized by numerous, widely distributed cutaneous and internal venous malformations. Pathogenomically, they are small, rubbery, dark blue, palmoplantar lesions and gastrointestinal vascular venous malformations. Prevalence unknown, no sex predominance. Like other venous malformations, blue rubber bleb nevus is associated with localized intravascular coagulopathy. Like the venous malformation, the syndrome is caused by activating TEC mutation. Clinical features. Most patients are born with large venous malformations. Additional small, less than 1 to 2 centimeter cutaneous lesions are present at birth and increase in size and number, often around puberty. They are dark bluish to purple, hyperkeratotic, and rubbery in consistency, especially frequent on palm and soles. The gastrointestinal vascular malformations are commonly located in the small intestine, but can be found anywhere from mouth to anus, and they causes the GI hemorrhage, chronic iron deficiency, severe anemia, intersusception, volvulus, and infarction. The vascular malformations can also involve brain, kidney, lungs, and other organs. Life expectancy should not be reduced if bleeding is managed well. So you can see this blue rubber bleb nevi on feet as well as in the intestinal mucosa. Management. Chronic anemia due to GI bleeding necessitates iron supplements and even blood transfusion. Aggressive surgical excision of all gastrointestinal lesions should be done in patients who require blood transfusion or who have frequently complain of frequent intermittent abdominal pain due to intersusception. Then targeted molecular therapies such as rapamycin have become an option after validation in clinical trials. Then the glomovenous malformation or glomangioma or glomus tumor. The glomovenous malformation are inherited as autosomal dominant. They are venous anomalies which are characterized by multifocal bluish-purple lesions, mainly on the extremities. The glomovenous malformation account for 5% of venous anomalies. Prevalence unknown, no sex predominance. More than 80% of glomovenous malformation are inherited as autosomal dominant trait. They have an age-dependent penetrance, reaches its maximum by 93% at the age of 20 years. In contrast to the venous malformation, GVM is not associated with coagulation and abnormalities. Pathophysiology. Histologically, glomovenous malformation are characterized by presence of ill-defined mural smooth cells, which are called as the glomus cells, surrounding the enlarged and dilated and convoluted venous channels. GVM caused by loss of functional dominant mutation in GVM gene encoding the glomin. The glomovenous malformations are congenital and never regress spontaneously. There is a great variability in number, size, and location of the lesions between the affected individuals. It varies from a few inconspicuous, tiny blue spots, often grouped to extensive lesions. GVMs are usually small in diameter, pink to purple in color, raised with cobblestone appearance, and slightly hyperkeratotic, especially when located on extremities. They are cutaneous, subcutaneous, and rarely involve mucosa, deep muscle, joint, or bone. They are not compressible but painful spontaneously and on palpation. You can see this excised glomus tumor, and on histology, the typical glomus cell are seen surrounding these vascular channels, which appear as slit-like spaces. This is another picture of a localized glomus tumor, and this is a large plaque of glomangioma. Investigation. The normal D-dimer and fibrinogen level. Doppler ultrasound is the best examination to confirm the slow flow nature of malformation and higher cellularity and weaker compressibility compared to the venous malformation. MRI with spin echo T1 and T2 weighted and fat saturated sequences depict the extension into underlying tissue. The histological and genetic analysis can give a definitive diagnosis. Management. Tailored compression garments are contraindicated in GVM as they increase pain. So the treatment of choice is surgical resection, and sometimes skin grafting is required. Sclerotherapy can be used, but it is less effective than other cases and have a higher risk of ulceration than the venous malformation. Pulse dye and YAG laser may be efficient for smaller lesions, but not for larger lesions. Genetic counseling is indicated. Then we have reached to another common syndrome, which is called as, important syndrome, which is known as the Maffuci syndrome. This Maffuci syndrome is characterized by multiple enchondromas, which are associated with superficial and deep, slow-flow venous malformations called as spindle cell hemangiomas. The sign and symptoms progress with time, causing gross deformities, especially on hands and feet. The risk of malignancy increase with age. Prevalence unknown, rare disease with less than 200 cases, no sex predominance. The spindle cell hemangiomas are composed of thin-walled, venous-like channels separated by spindle fibroblastic cells. So you can see this spindle fibroblasts surrounding these venous channels in Maffuci syndrome. The syndrome belongs to spectrum of enchondromatosis. Enchondromas are hamartomatous proliferation of chondrocytes leading to abnormal endochondral ossification of the diaphysis or metaphysis of the bones. They can appear anywhere. When bilateral, they are asymmetrical. Then spindle cell hemangiomas are subcutaneous, firm bluish nodule, usually appear around puberty on fingers and toes. Patients with Maffuci syndrome have a significant risk for appearance of skeletal and non-skeletal malignant lesions. You can see these vascular malformations and multiple enchondromas. These enchondromas may degenerate into chondrosarcomas. The appearance of pain and increase in volume are the clues. Other mesodermal neoplasms that are associated with Maffuci syndrome include fibrosarcoma, glioma, astrocytoma, ovarian tumors, hemangiosarcoma, and leukemia. Therefore, special emphasis on careful and prolonged clinical follow-up and imaging studies is indicated. Investigations. On conventional radiographs, enchondromas are radiolucent. There are multiple oval-shaped osteolytic lesions with well-defined margins at the metaphysis or diaphysis of long tubular or flat bones. The D-dimers level are normal, in contrast to the vascular malformation. Histological analysis confirms the diagnosis. When there is functional impairment, surgical excision of spindle cell hemangiomas and enchondromas are necessary. Malignant lesions should be treated surgically whenever possible. Then the last topic of today's lecture is the lymphatic disorders. So the lymphatic anomalies comprises of lymphatic malformations and various types of lymphedemas. Lymphedema is the accumulation of lymphatic fluid in connective tissue and is divided into primary and secondary. The latter is caused by extrinsic factors such as infections or surgery. The primary lymphedema is inherited depending upon age of onset, and primary lymphedema is divided into type 1, which is congenital lymphedema that is present at birth, and type 2, which is the precox or the Meeks disease appearing after puberty. And the third type is lymphedema tarda that appear after the age of 35. Lymphatic malformations include the cavernous lymphangioma, cystic hygroma, lymphangioma, and lymphangioma circumscriptum. So these are the healthy lymphatic channels which take the lymph from the dermis and drains it into the veins. But in lymphatic malformations, these lymphatic channels, they become huge and large, dilated, with lots of fluid accumulation. Lymphatic malformations are the focal lesions composed of dilated lymphatic channels disconnected from the lymphatic system. The lymphatic malformations can be macrocytic, microcytic, or combined. The lymphatic malformation occur sporadically and are rare diseases. Exact prevalence unknown, no sex predominance. The macrocystic lymphatic malformation composed of single or multiple lymphatic cysts surrounded by thick fibrous membrane. The microcystic type is characterized by dilated lymphatic channels with variable thickness of their wall. Blood can be seen in the spaces after intracystic bleeding or in a combined lymphatico-venous malformation. The lymphatic malformation can be seen as a component of a syndrome, such as Klippel-Trenaunay syndrome and CLOVES syndrome. Clinical features. The macrocytic lymphatic malformation are often located on neck, chest wall, and axilla, manifest as multilobulated, well-defined lesions that are translucent, soft, but only slightly compressible on palpation. So these are the macrocystic lymphatic malformation located on the shoulder, on the face, on the lip, involving the tongue. The microcystic lymphatic malformation are mostly located on head and neck. They are ill-defined vascular papules, which often invade adjacent structures. Skin can be normal in color but becomes blue or purple when intracystic bleeding occurs. The capillary-lymphatic malformation or angiokeratoma circumscriptum is a hyperkeratotic plaque with small keratotic blood vessels located on the extremity. Lymphatic malformations often cause asymmetry with bone overgrowth, especially on the face. You can see this bone overgrowth as well as the lymphatic swelling. It can suddenly become painful and large due to intralesional bleeding or infection. There can be recurrent erysipelas or cellulitis as a major complication which need to be treated promptly to avoid septicemia. Among investigations, Doppler ultrasound is the best examination to perform to confirm the cystic nature and slow flow vascular malformation. Then MRI is important to depict the anatomical relationship between the vascular lesions and adjacent structures. Management. Bacterial infection managed with antibiotics and pain management. Then complete surgical excision can be performed, planned depending upon the anatomical site and extent of the lesions. Recurrence is frequent in microcystic variety. The macrocystic lymphatic malformation is treated by fluid aspiration followed by percutaneous intralesional injection of sclerosing agent. And the available sclerosing agent here is OK432, which is an extract from the killed strain of Streptococcus pyogenes. Also used is doxycycline, bleomycin, and ethanol. Sclerotherapy can be followed by fever, erythema, and edema. Microcystic dermal lymphatic malformation is treated with laser. Rapamycin has promising clinical trial. Sildenafil is also shown to have some effect. Primary lymphedema type 1, also known as the Noni-Mallory disease. Noni-Mallory disease. Hereditary lymphedema type 1 is autosomal dominant. Congenital lymphedema consists of accumulation of lymphatic fluid in connective tissue. Prevalence unknown, but probably and most frequently probably the most frequent form of primary lymphedema. Male and females are equally affected. This is caused by loss of function of dominant mutation in FLT4 of vascular growth factor receptor 3 gene. The hereditary lymphedema type 1A, characterized by lower limb bilateral lymphedema, localized below the knee and usually present at birth. A few families present with pleural effusion, chylous ascites, and hydrops. Other associated features include hydrocele, prominent veins, up-slanting toenails, and papillomatosis. Lymphedema can improve spontaneously even prenatally. Then lymphoscintigraphy has replaced lymphography as an investigation of lymphedema. You can see that bilateral swelling of the lower limbs below the knee. Then hereditary lymphedema type 2, which is the Meag lymphedema. This is a late onset lymphedema, usually at puberty, involving the lower leg but can also affect face and upper limb. It is associated sometimes with cleft palate and yellow nail. It is an allelic to syndromic form of inherited lymphedema caused by COX-C2 mutation. The management is mainly symptomatic with elastic garments and manual lymphatic drainage as a gold standard approach. Cellulitis and recurrent cellulitis is treated by appropriate antibiotics. Suction-assisted lipectomy in combination with post-operative elastic compression is helpful. Genetic counseling is required. Then lymphedema distichiasis syndrome. This is characterized by late onset lower limb lymphedema associated with typically double row of eyelashes from the meibomian glands, and this double row of eyelashes is called as distichiasis. Prevalence unknown, and there is an important intrafamilial variability. Male seems to develop syndrome earlier. This syndrome and yellow nail syndrome are caused by loss of functional mutation of COX-C2 gene. The clinical feature is that of lymphedema, which starts at puberty, but can be early presentation, and hydrops fetalis is possible. Then distichiasis causes corneal irritation, infection, and photophobia. Other associated features include venous, varicose veins, cardiac malformations, cleft lip, ptosis, and yellow nail. There are a few other syndromes which are associated with lymphedema, like which is seen as generalized, prenatal, or postnatal, with high variability among the patients. And these syndromes include the Turner syndrome, the Noonan syndrome, the Costello syndrome, and cardiofasciocutaneous syndrome. So this brings to the end of this talk. Although a long lecture, which most of my lectures are, but I tried to cover most of these vascular malformations, and I hope this would be helpful for you in your exam and in clinical practice. Thank you and have a good day.